This meeting is now being recorded.
Well, good evening. Welcome to our EDS Awareness Educational Series webinar. My name is John Furman. Before we introduce our speaker, I'd like to give an overview of our free program for those attending for the first time. So we'll go over who we are, what is our program, some upcoming events, and then introduce our speaker this evening, Dr. Chopra. Unfortunately, we won't have time for Q&A this evening. So again, my name is John Furman. I manage the National EDS Awareness and Chronic Pain Partners nonprofit organization based in Cincinnati, Ohio. My daughter, Deanna, who is also on the call, leads the Cleveland, Ohio EDS support group. She was diagnosed with hypermobile EDS in 2008, the same year my wife, Carol, passed away with breast cancer. I was a caregiver for my wife who struggled with undiagnosed EDS for over 30 years. We introduced our program at the 2012 EDNF conference to help EDSers form independent local support groups and spread EDS awareness in their communities. We have been a sponsor for these conferences for the last 5 years. We've helped to start over 100 groups to date. Each group is given their own free website with a link from the directory and map. We receive feedback that conferences provide valuable information and social opportunities, but many cannot afford physically or financially to attend in person. So we decided to bring the speakers to you through the free EDS Awareness Educational Series. We typically meet each month at 7:30 Eastern Standard Time, so we're flexible on that at times. All the programs are free. The meeting announcements, and whenever possible, the webinar recordings will be posted on our website at edsawareness.com for later replay. You can receive email announcements for future sessions by requesting the free guide on our site. Tonight's presentation is sponsored by Body Support Store, where you'll find over 250 products selected by EDSers for EDSers. Proceeds from this store and donations to our nonprofit organization help fund our programs. Please visit our store and check out the helpful products that we offer. Just a general disclaimer. This presentation contains general information about EDS. Members of the EDS community voluntarily participate in this program. The information is not advice. If you're having medical problems now, please call 911 or the emergency services in your location. Always consult your doctor before making any changes to your treatment.
And as we mentioned, there will be a second half to Dr. Chopra's presentation coming up in May. Normally we would have Q&A, and you can anticipate Q&A for that second part of this session. However, tonight we will be presenting a lot of content, so we will not be having Q&A until the entire two-part series is concluded. So join us then if you have questions you'd like to submit. And you can normally do that by attending the live presentation. And we wanted to introduce Dr. Chopra. I have a brief overview of his bio I wanted to provide for you. He completed his anesthesia residency and fellowship in pain management from Harvard Medical School. And he's a recipient of several awards and the author of several publications on chronic pain, including several book chapters. He holds the appointment of Assistant Professor, Clinical Department of Medicine at Brown Medical School, and the Assistant Professor of Anesthesiology at Boston University School of Medicine, as well as he is double board certified in pain management and anesthesiology. He is a member of the editorial board for Chronic the Journal of Chronic Pain and Symptom Palliation and Pain physician, and he, of course, has an interest in both acute and chronic pain management, and particularly with Ehlers-Danlos patients. And his approach for chronic pain patients is to get them to the point to allow them to do the things they want to do and not let pain take over their lives. And many EDSers have been very appreciative of his compassionate approach to helping them with pain management. So I'm very pleased to welcome Dr. Chopra back to speak with us. And I'm going to go ahead and load his presentation. And Dr. Chopra, thank you for being here. I'm going to turn the microphone over to you, and we're looking forward to your presentation tonight.
Thank you, Deanna. Thank you, John. Nice to be back again. You can hear me, right?
Yes, you sound great. Thank you.
Is my sound coming? Okay. Good evening to everyone. Good afternoon. Good morning. So we're here to talk about, this is about connecting the dots. So we know Ehlers-Danlos syndrome, we know it's got a connective tissue disorder, joint problem, pain problems. Then there's talk about POTS and dysautonomia, then there's talk about mast cell activation syndrome, and all sorts of conditions that come along with it. But the overall goal here is to, how do we connect everything together and figure out, like, okay, so what's POTS and which part of my pain is coming from POTS and which part of my problems are coming from mast cell or from my joints. That's going to be the overall goal for this presentation. I'll talk about some of the treatments. A lot of the treatments that I'll talk about are not exactly in a textbook, but just learn from experience and a bit of science here and there. We've already gone through this. I don't have any conflict of interest. I might be discussing, in fact, I will be discussing off-label uses of medications, and always check with your physician before you make any changes, but this is not to replace any advice. So as you all probably know that on the 15th of March of this year, we had new terminology come in, and it really it gave Ehlers-Danlos syndromes a much more stronger foothold in the world of medicine. Prior to this, it was, okay, what is joint hypermobility and what is Ehlers EDS? And there was a lot of confusion about it. So with the new guidelines, it's kind of solidified everything. I'm not here to talk about the new classification, but I just wanted to mention the first line here. As you can see, Ehlers-Danlos syndrome is now Ehlers-Danlos syndromes. And we've now got hypermobility EDS. It's going to be called as hypermobile EDS. And the acronyms are going to be the small letter H followed by the capital letters EDS, or for vascular it'll be small letter V followed by EDS. And then there's a whole subset of conditions called hypermobility spectrum disorders. It's a kind of a dumping ground for some people who probably have EDS, but we really don't meet the criteria. And so not to leave them out of the treatment protocols, we're hoping to put them into the hypermobility spectrum disorders. And the old classification of using numbers, etc., is gone for now. So that's about the terminology. I just want you to know that EDS is not a disease. I don't want you to consider it being a horrible, life-threatening disease. It's another form of the human body. Just like there are tall people and then there are short people. Tall people have their own medical conditions versus short people. Black people have their own medical conditions versus white people. It's another form of the human body. And because of this different form, there are different medical conditions which we have to approach differently. Unfortunately, EDS has been neglected for the longest time. Thankfully, people are getting more and more aware. There's more and more research coming up, and so hopefully we'll have a lot more better outcomes. There are a couple of things to remember about EDS. One is you have to understand that the human body is made up of different parts. So we have bones, muscles, skin, tissue, and they're all connected to each other. So my bones are connected to my bones, my muscles are connected to my bones, and they're all connected by what is called as connective tissue, hence the name connective tissue. Literally everything in the body is made up of connective tissue. So in terms of managing pain, the crucial thing is there's no such thing as pain management. If somebody came in and walked into my office, called me up and said, hey, listen, I have a pain in my wrist, there's no protocol for that. I can't make a decision as to what to do for that pain unless I know what's broken. So the idea behind treatment of EDS or treatment of pain in EDS is to figure out what's broken and fix that, and hopefully that'll decrease the pain. So just to give you an example, if someone comes in with pain in the shoulder joint, it could be anything. It could be a dislocated shoulder joint. It could be a muscle spasm. It could be an impingement or damage to one of the nerves or blood vessels. It could be all of them. And of course, if it is pain from a dislocated shoulder joint, the treatment for that is vastly different from treatment of pain that is coming from a nerve around the shoulder joint. So the idea behind pain management is to find out what's broken and let's fix it. So in terms of EDS, there are two things to remember. One is that we have weak connective tissue, and we also have poor joint position sense. And I'm going to elaborate on both of them, what that means in real life. What does that mean? So connective tissue is like a rope, and like the strands of a rope, the collagen is part of your connective tissue, and it's the collagen that's weak. And the normal, I'm sorry, I don't like using the word normal. Connective tissue in non-EDS people is strong. It doesn't stretch. It doesn't break easily. And when it does break easily or when it's cut, it heals well. In EDS, this connective tissue is made up of collagen, and the collagen is weak. So it stretches easily. It breaks easily. The biggest problem here is that it does not heal well when it breaks. And or when it overstretches, it doesn't heal well. And that's where we are. That's the major problem with EDS. This is just to show you what I mean by that. So this is a typical scar from an EDS patient. And as you can see, the tissue in the middle of the scar is paper thin, which is classically known as cigarette paper scar. In this case, it's a cosmetic issue. But imagine if this was if we traumatized any of our connective tissue inside, if a ligament broke or overstretched inside the body, it would heal with the same weakness. And that's the scary part about EDS is, like, do we want the tissue to heal like this? And that's one of the reasons why surgery is not usually recommended in EDS, is because they usually heal with this kind of a weakness in the middle. Now, broadly, you can divide trauma that we feel that we have is either macro trauma, where a large event happens, or such as a fracture or a dislocation. And what's more common is the micro trauma, which is a small repetitive stretching of the muscles, of the ligaments that happen on a daily basis that we are not even aware of. So the human body goes through a constant process of breakdown and repair every single day. And when we are younger, the repair is much faster with the breakdown, and as we grow older, the repair doesn't catch up with the breakdown. In EDS, what happens is that besides the macro trauma, besides dislocating or subluxing the shoulder joint or the knee joint, it's the micro trauma that is much more damaging. This is an example of a macro trauma. Here you can see the finger joints have dislocated. Over here we see they're dislocated and subluxed. You can see there's a fracture over here. That's what we call as a macro trauma. But what's more often is the micro trauma that happens over here, and you can see micro tears in the ligaments, in the tendons, and this is what occurs on a daily basis all over our body. The second thing that we really need to understand is proprioception. There's a lot of talk about joint position sense of proprioception. What really happens in proprioception is that the brain is constantly, it's like, imagine the brain being like a computer control center of a large factory, and it's constantly getting information from different parts of the body, letting it know exactly where your body is or where your different parts of your body are. So, it helps us walk. So I don't have to look at the floor as I walk. I don't have to look at my feet and balance myself. It happens automatically. And the reason it happens is because the brain is constantly getting feedback from exactly where my knees are, where my ankles are, where my arms are, and so we balance ourselves. But what's more important is that it protects our joints from hyperextending, and it protects our muscles from overstretching. And so, if you look at your joint that hyperextends, the reason my joint doesn't hyperextend is because at one point there's a signal that comes from my elbow joint. A signal will go to my brain saying, "Okay, that's it. You can't go anymore." But in your case, there is no signal going, or the signal isn't really that strong, and so you continue to hyperextend. And once you continue to hyperextend, there's a good chance we are causing these micro traumas. And that's what makes, of course, clinically, that's what makes us so uncoordinated. But more importantly, it's the damage that's done by proprioception, a poor joint sense, a joint position sense. This is actually a little diagram to show you what I mean. So as we walk, signals travel up the leg, from the foot, from the ankle, go up to the knee. The knee sends signals, letting the brain know exactly what angle it is, what height it is, and these signals go up the spinal cord into the brain. The brain then processes this, and then sends back signals to different parts of the body to balance us and protect us. So what happens is with repetitive wear and tear of the joints, we start to lose proprioception. This is not something particular to EDS only. It is a normal physiological response. It is seen in arthritis. You see that athletes lose them a lot, athletes lose them a lot, and that's basically what it is. But the problem with poor proprioception is that because we are so uncoordinated, it makes us lose balance. And when we lose balance, the body has to counteract by straining other muscles. And because we're not using our muscles efficiently, this adds to the fatigue, the tiredness, and the pain. So at some point, I'll talk about fatigue, but this is one of the reasons for fatigue. Not the reason, but this is one of the reasons, because our body is constantly struggling to get us into the right position, struggling constantly to keep us moving. That's one of the reasons why people with EDS feel fatigue. It's a normal physiological phenomenon. You can see that in toddlers, it's not yet developed, and so they tend to fall a lot. And in the elderly, they lose it because of joint damage. One of the tricks that have been used to replace this is that we know that the skin has receptors, or proprioceptors they're called, there are sensors in our skin that also send signals back to our brain as to the position. So we can trick the brain by if you wear something that is skin tight, the brain uses that signal from the skin as a way of understanding where the joints are. There are all kinds of compression garments that one can wear. This is a knee compression sleeve. This is a full compression sleeve that goes up to the leg. It covers the knee joint and the hip joint. And then, of course, there's a dual advantage to using this. And I'll talk about it when we get into POTS. The compression from these garments can also help with symptoms of POTS. So how do you fix proprioception? Some of the ways to fix proprioception, they're actually one of the easiest exercises. You can do what is called juggling. You can do juggling, balance board or a wobble board, Stokes standing, which is you stand on one leg. Now, when you first do that, you stand holding on to something and then you let go. And when you first stand, you keep your eyes open and then you can practice with your eyes open. Stand up, paddleboard, sitting on an exercise ball. Exercising in water is another great way of improving proprioception. This is a wobble board. This is a stand-up paddleboard. It's great for proprioception. It also is very good for building up core muscles. The other type of exercise, there are different types of exercises I'll talk about in EDS, and this is another type, which is muscle strengthening exercises, which is a standard exercise that you'll see in physical therapy. I just want to point out a few things about muscle strengthening exercises. One of them is to avoid joint loading or joint stressing. So any exercise that involves that you do for strengthening muscles, make sure that you're not stressing the joints or stressing the or a joint or causing any pressure on the joints. Start very low. Start really, really low. I mean, if the recommendation is to say use take 5 pounds and do 10 reps, my suggestion would be to start with 1 pound and do 5 reps, and then stay on that for a week or two, and then progress to say 6 pounds and do 5 reps. So you have to progress really slowly. And the reason why I say that is because, remember, in EDS, healing is slow and it's not great. So once you cause some damage by over-exercising or exercising too much, the damage that it does doesn't get better easily. It takes time for it to get better. So always start really slow and progress slowly. Focus on muscle strengthening and avoid extreme stretching, because remember something, your ligaments aren't really doing a great job of supporting the body, so you have to depend on your muscles to hold you in place. And if the muscles are tight, there's a reason why they're tight, and so stretching those muscles is going to cause more damage. So avoid any extreme. Some stretching is okay, some passive stretching is okay, but going to great lengths to stretch them is not a good idea. This is something I wanted to point out also. When you're exercising, stay within the range of your movement. So, for example, on the hip, you can move from, say, 0 degrees to 90 degrees. But when exercising, stay within the range. So stay within 60 degrees to 0 degrees. Obviously, in the hip, you can go much higher if you're standing. But stay short of going to the extreme on both ends. So again, you would say if you're doing an exercise with your elbows, you want to stop short of hyperextending it, and you want to stop short of hyperflexing it. This is really important because, again, you have to be careful when you do it. You have to watch yourself while doing it. Exercising in water, this is key, and I'll tell you why for many reasons. One, remember, the contact of water with your skin gives you a sense of, tells your brain your exact position in space, and that helps it coordinate your movement. So coordination of the joint movement is really helpful when you do that in water. It's like having a compression garment around your body. The second thing it does is it of course reduces our weight, the weight that we're putting on the joints. It reduces that significantly. So you can allow the muscles to exercise without causing any damage to the joints. What I don't recommend about exercising is swimming, because especially if you want to do the crawl, this is called the crawl. This can damage the shoulder joint. It damages the neck joint. So I don't really recommend this. If you really want to swim for getting your aerobic exercises, the best thing to do would be to hold on to a kickboard and paddle with your feet. And you can use a snorkel to avoid rotation of your head and neck. So again, this is the same thing. So exercising in water is great. It helps the brain understand your exact position. You can exercise without causing any damage to your muscles and joints. Avoid swimming. This is actually the Feldenkrais method is a very old technique of exercise. It's ideally developed for patients with EDS. Moshe Feldenkrais was a physicist who first came up with this idea. He had injured his knee, and he was told by his doctors that he needed knee surgery, and he decided that he was going to avoid knee surgery, and so he came up with this technique. The exercise, what it does is it helps repair impaired connections between the brain and the body. Again, I'll talk about it later on. What happens is when you have chronic pain in any part of the body, the brain tends to neglect that part. And so it really helps repair those connections. Now, patients with EDS over the years develop inefficient or strained habitual movement patterns. The Feldenkrais method teaches new patterns to be and using very gentle and slow repeated movements. And these exercise techniques are very safe for EDS. It helps in improvement of proprioception. The beauty of this method is that it can be done sitting or lying down. Each of these exercises are really comfortable, easy movements, and are within the limit of safety. This is a picture of people doing Feldenkrais. As you can see, they're sitting. You can do it lying down. This is a great website to go to. They have lots of resources, and in fact, if you plug in your zip code, they can tell you about any members or any providers in the area that do offer Feldenkrais method of exercising. So there's a lot of talk about tendonitis and bursitis. What does that mean? It's pretty simple. What happens is that this is a normal joint. So you have two bones, and then there's a capsule around the bones joint, and then there's a muscle and a tendon that glides over the joint, because when this muscle contracts, it pulls this joint and this bone moves up. Now, in order to avoid this muscle and tendon from getting abraded by the bone, there's a little pocket of fluid between this muscle and tendon, and this pocket of fluid is called a bursa. For any reason, especially in EDS, what happens is when the joint subluxes, and all it has to do is sublux a little bit. Once it subluxes, then the alignment is thrown off, and so now the muscle and tendon are pulled a lot more, and eventually this bursa gets so rubbed against the bone that it starts to get inflamed. The reason I say this is because treatment of bursitis doesn't lie in treating this bursitis alone. It doesn't matter what injections I do here. It doesn't matter what topicals we put here. It's not going to fix the problem. What's going to fix the problem is to get the joints in alignment. So treatment of tendonitis and bursitis lies in correct bracing to align the joints, correct posture, especially when standing, avoid repetitive use of the joint. So if this joint is the problem joint, so as long as you can give it some rest, letting it heal up and come back in alignment, the bursa will start to calm down. Maintain proper balance. So subluxations and dislocations, what does that mean? There's a lot of talk about subluxations and dislocations. It's really simple. In subluxations, there is a stretching of the capsule around the joint. It's not torn, it's not broken, it's just stretched, which means the joint slips out and slips back in. And this is the most common type of trauma in EDS. And then you have the dislocation where the capsule tears off, and then now the bone is really off its position and has to be manually brought back. So the problem in subluxation and dislocations is not the tear in the joint or the stretching of the capsule. That happened a while back. Most of the pain in subluxation and dislocations is from the muscle spasms around the joint. So there are muscles around the joint that will try to keep it in place to prevent it from subluxing or dislocating, and that's where the pain comes from. So again, pain in subluxation and dislocations is not the joint per se that's causing the pain, it's the muscle surrounding the joint that causes the pain. Classically, if you look at the shoulder joint, the shoulder joint, when it subluxes or dislocates, the muscles of the rotator cuff will go into a spasm, and when that goes into a spasm, that's where the pain comes from. The minute you put the joint back, the muscles are happy again, and it relieves the pain. I will mention a lot about kinesio taping or neuromuscular taping. It's a really great technique, especially in EDS. You must have seen athletes using that a lot. It's a very simple tape. You can actually do it yourself. There's some great YouTube videos. There are some DVDs you can get, or your physical therapist can show you how to do them. So the idea behind kinesio taping was that the tape looks like this. It has fingerprint-like patterns on it. So the adhesive is in a fingerprint pattern. So it's almost like somebody's finger is stretching the skin over the area. It is designed to stretch. So depending on how much you need, you can stretch it to, say, 20%, 50%. It is porous, so it allows drying easily. You can take a shower in it. Most companies that manufacture it say that you can keep it on for 5 days, but I generally recommend changing it every 3 days. By the 4th and the 5th day, it's kind of lost its elasticity. So the tape, what it does is it stimulates the sensors. Remember I told you there were sensors in the skin, the proprioceptors in the skin. So it stimulates the sensors in the skin. It's a great way of reducing swelling. It reduces pain, it improves proprioception, it relaxes the muscles, stabilizes the joints, and it supports weak joints, it reduces swelling. It can literally be used on any part of the body, the neck, the upper back, even the feet. This is a paper that was published in 2015 on using kinesio taping for the knee in EDS specifically. I'm sure you can get this off when John puts this online. You can take that. But it's a great technique. I do use it, and it works really well. It's worth trying it. You can do it yourself at home once you learn the trick. So, like I said, to manage pain in EDS, one has to know what's broken. And there's no uniform treatment for pain. So I'm going to talk about pain in EDS by body regions. So we talk about head and neck, shoulders and arms, abdomen, legs, spine. They all have their own peculiarities. Let's talk about the head and neck. So there are lots of reasons for having headaches. I've just listed some of the more common ones, but I think the last time I counted there were 22 of them. You don't have to have all 22 of them. I've left out some of the rare ones, and I'll kind of touch on all of these at some point. So carry malformation, Cervicogenic headaches are the common headaches, what we call as tension type headaches. These are from the muscles around the head. Temporomandibular joint dysfunction, vision, POTS, tethered cord syndrome, spontaneous CSF leak, craniocervical instability, and idiopathic cranial hypertension. So, but I'm going to start with the more common cause of pain, neck pain and headaches. One of the most common causes of neck pain and headaches is posture. We all tend to have a chin poking forward position, but what happens is that in EDS it puts an extra amount of strain on the ligaments. So what happens is you're trying to stick your chin out, and just like you're trying to read something on the computer or trying to look at something on your phone, your chin pokes out. That causes the ligaments in the back of the neck to stretch, and this is a really more common reason. And so I want you to think of these before you think of some of the more exotic conditions like Chiari malformation or cervical instability. So classically, the question is, how heavy is your head? It's about 10 to 12 pounds in the normal posture. So that means the normal posture is, let me get my presenter. So the normal posture is where the ear is in line with the shoulders. The pressure that the head applies on the neck is about 12 pounds, which is the equivalent of a bowling ball. If your head leans forward by 2 inches, the pressure is now 32 pounds. So it literally almost goes 2.5 times the pressure when you're in the anatomical position. If your head goes forward by 3 inches, the pressure is 42 pounds. So this is what I mean by is the chin poking forward position, which means the neck starts to poke forward. So this you can see over here, how the neck when it pokes when you have your chin in poking forward position, the spine, the cervical spine, the vertebrae in the cervical spine start to stretch. The ligaments start to stretch. And that really just translates to pretty much the entire spine. So this is the normal one. This is the correct head posture. So where your ears are in line with the shoulder. The shoulders are squared. The pelvis is level. And the center of gravity is in your tailbone at the S2 level. So everything looks hunky-dory over here. None of us, EDS or not EDS, none of us have this posture. But in EDS, it becomes a lot more significant because, remember, we're talking about a 42-pound pressure on the head or a 32-pound pressure on the neck. So the neck starts to hurt, which then throws the spine off and then eventually wind up with back pain, eventually wind up with hip pain and knee pain. So this is how important it is to get the correct posture. Why would people have poor posture in EDS? One, and this is what I've seen in practice, is a blurry vision. And most people with EDS don't realize that they have intermittent blurry vision. So you might have a blurry vision today, you may not have it tomorrow. And the problem with that is that when you go to the optometrist, you don't finally getting the right glasses. There are lots and lots of reasons for having blurry vision in EDS. One, the eyeball is made up of connective tissue, and in this case, the eyeball is thinner. And because it's thinner, the volume of the eyeball changes dramatically as the pressure in the body changes, or the blood volume changes. And why would your blood volume change? Well, our blood volume changes if you're dehydrated or something. But again, if you have POTS, the blood volume is going to change. Once the blood volume changes, the eyeball size changes much more rapidly. They also tend to have things like keratoconus, astigmatism. So even to the point that some patients with EDS will actually have one eyeball a different size from the other eyeball. So there are lots of reasons for having a blurry vision in EDS. POTS is another reason that makes them lean forward, which causes blurry vision. And then the instability of the head. The head just weighs way too much, especially once you lean forward a little bit. Now it's weighing 32 pounds, and so you tend to fall forward even more, and it just spirals on, and so you tend to lean forward a lot more with your head and neck. This is what it should be ideally. So the green dots, so imagine your ears being in line with your shoulder, which means that you want your chin to push back slowly, and you have to do it slowly. It takes time to get to this, but once you get to it, you will get it. It's pretty helpful. It helps a lot. But in the beginning, it is very hard. Like in all habits, it's really hard to change habits. What I suggest is you place an index finger in front of the chin and push back your head gently till the ears are in line with the shoulders. When you're using a computer, use a large monitor so you don't have to squint and peer into it. I recommend putting a post-it note on the monitor. Don't write anything on this post-it note. Leave it blank. So every time you look at it, it will make you think, why did you put the post-it note? It's like having a picture on the wall. You know what the picture is. But if you have a blank post-it note, it will make you think about, okay, I need to put my index finger and get my posture corrected. Of course, getting vision corrected and managing the POTS is other techniques that you can use. Again, lift the phone up to your head. Don't bring your head to the phone. Migraines. This is just one slide on migraines because migraines is a whole 3-hour talk. But migraines is very common in EDS, and migraines is more common in women, and EDS symptoms are more common in women. So again, it's a double whammy. But there's a strong connection between Ehlers-Danlos syndrome, mast cell activation syndrome, postural orthostatic tachycardia syndrome, and dysautonomia and migraines. Patent foramen ovale. This is a kind of a hole in the heart. It's not a dangerous condition, but because of EDS, a lot of patients can have this. So this is something to look for. They have been able to show that treating the patent foramen ovale actually treats migraines in a lot of cases. There's a strong link between diet and migraines. We know that. Chocolates, dark wines, red wines, old cheese. The good news about migraines is that there are many new medicines that are out there specifically for aborting migraine attacks and preventing migraine attacks, and they're just coming out more and more every year. How do you know what kind of a headache do you have? So this is a little pictorial. So if it's more in the front, if it's more around the eyes and the cheeks, it's a sinus headache. It's like a really tense, pressure-like headache. The easiest way to figure that out is if you lean forward with your head down, the pressure in the headache is going to get intensely worse. Cluster headaches are actually more common in men than in women, but it's classically pain around the eye, and it's usually just one eye. But again, migraine, clusters are a type of migraine, but again, most migraines are around the eye, but they're also around the head. Tension type headaches are in the front of the frontal region. This is the front of the head, and they're also in the back of the head, in what is called the occipital region. And a classical migraine headache is usually one-sided. It's throbbing. It's associated with nausea. There is sensitivity to light, sensitivity to sound. So in the guidelines that came out on the 15th of March, this was one of the headaches that was discussed. And the reason I'm bringing it up is not because it's common, but because it's missed a lot. This is also, it's called the idiopathic intracranial hypertension. What that means in English is that there's an increase in the pressure inside the head for unknown reasons. It's also known as pseudotumor cerebri. I don't like to use that term. Sounds scary. So we stick with idiopathic intracranial hypertension. These patients usually present with visual disturbances. They have sensitivity to light. They have ringing in the ears. oftentimes it is because of narrowing of blood flow in the brain. So there are venous sinuses in the brain that drain blood, that pump blood around the brain, and these are called venous sinuses. And you can detect that on an MR venography. Spinal tap will show an increase in pressure. An eye exam can show some changes. Treatment is usually weight loss, and then there are medicines to decrease the cerebrospinal fluid, which is the fluid in the brain, around the brain. VP shunt is called a ventriculoperitoneal shunt, which is a little tube, kind of drains the fluid out of the brain. Or they can stent the stenosis, the narrowing of the venous sinuses. This is again, I do see this, and it's often a missed cause of headaches. So what this really means is that CSF stands for cerebrospinal fluid. And so the brain and the entire brain and the spinal cord is floating in fluid. So this blue color stuff is fluid. It's called the CSF. And so the brain and the spinal cord are cushioned by this fluid. And it's a process where the fluid actually is produced in the brain, and then it flows down the spine, and then it flows back up again. And so there's a constant circulation, there's constant production of CSF. It's a closed system, so there's nothing going out from it. But in some patients with Ehlers-Danlos syndrome, there's a leak in the sleeve that holds this fluid in place. We don't exactly, it's very hard to figure out where the leak is. There could be many leaks. There are maybe microscopic leaks. It's hard to figure out. But classically, these headaches go away when you lie down, and they come back the minute you stand up. Remember again, they go away, they almost go away completely with lying down, and they come back instantly the minute you stand up. So that's a spontaneous CSF leak. So I chose these two reasons for headaches was because there are other reasons for headaches also, and I'll get into that when I talk about neck pain. But the common reasons for headaches is everybody knows about them, but I just wanted to bring this up so that people understand that there are other conditions that can be missed classically. Let's talk about upper back pain. Upper back pain, this is the pain around on the back of the shoulders near the wings, and even covers the neck. So it's usually due to poor posture. It can be from shoulder instability because there's muscles that control the shoulders are mostly in the back. It can be from rib subluxation. It can be from something called repetitive strain injury, also known as RSI. It usually happens with repetitive tasks, like in typing or using a mouse. And so oftentimes it's the right hand because we use our mouse in the right hand, or something like vacuuming. In women, it can be because of the weight of the breast tissue dragging the upper torso. So what happens is breast tissue kind of pulls you forward, and then the muscles in the upper back pull you backwards. So that's how we are able to stabilize our torso or the upper back. But in EDS, what happens is that the ligaments aren't doing a great job of supporting the upper back, and so the muscles have to work extra hard. Fortunately, one of the things women can do is try a sports bra with these requirements in them: a racer back, cross straps, wide straps so they give you better support, front closure to avoid subluxing the shoulder joints, proper fitting. It's best to get them done, get it sized. If you go to one of the department stores, they'll size it properly so that it fits well. And then, of course, in extreme cases, because of intractable upper back pain, one has to consider reduction mammoplasty. This is a pictorial to show you what I mean by a racer back. This is how So this pulls you back. It has to be a wide strap. And what it does is, because the breast tissue pulls one forward, these muscles have to work harder to pull you back. Normally, in patients without EDS, what this would do is the ligaments would do the job. But because the ligaments are loose and lax, EDSers have to depend on their muscles to do that. And so finally, they start to develop upper back pain. One of the key things to remember is the racer back has to be up here, up on the upper back, not lower down here. If you can't find it, if you can't find a racer back, then other trick you can do is use a bra clip to bring these together as high as possible. So, and of course, compression garments that improve proprioception. These you can pick up at any sports stores because remember, athletes also lose their proprioception because of repetitive joint injuries. Let's go to neck. So again, the cervical spine is really it's an amazing part of our body because it supports our head and it balances our head. Remember, the head weighs about 10 to 12 pounds, and it's well balanced on our neck. And it does that because of how the bones articulate with each other, but it's also done because of ligaments and muscles around there. Craniocervical instability, very commonly there's a C1, C2 instability, there's lower cervical kyphosis. Cervical disc degeneration is common in EDS, especially at C4, C5, and C5, C6. And of course, there's neck pain from Chiari malformation. So in craniocervical instability, so cranio meaning the head, the skull, and cervical being the neck. So at this junction, so let's talk about what happens at the junction where the skull meets the spine. So again, the neck is stabilized by ligaments, and the laxity of these ligaments causes the joints in the neck to move more. And so as the neck moves more, the head falls, forward, falls to the side, and the muscles have to work harder. The joints aren't that stable. So all this causes cervical instability. Craniocervical instability. So I've divided into two parts: the upper cervical, which is the CO, that is cervico-occipital, the occipital region, which is the back of the head, to the C2. These symptoms are different from the lower cervical spine. The upper cervical spine is neck pain, stiffness, often present with headaches, dizziness. They have this tingling, may have a tingling sensation to their face, fatigue, poor sleep, tinnitus, that's ringing in the ears. Again, they are lightheaded, they have poor balance, and they have difficulty swallowing. This is the upper joint that I talked about, the Atlanto Axial instability, which is where again this is where the upper two vertebrae articulate. They're differently formed because it allows for movement of the head in all sorts of directions. Atlanto Axial instability is very common. In fact, 50% of patients with rheumatoid arthritis have it. So it's kind of a good news because there are so many people that have it. There are more surgeons, and then there are more treatments out there that we can share. We have experience with. It's common in Marfan syndrome. It's one of the most mobile joints in the body to allow the head to move in all sorts of angles. In EDS, there are these two ligaments, the transverse and the alar ligaments, that are stretched. Now, the thing here is that the C1, which is the first vertebra, rotates over the C2. If it rotates more than 35 degrees, the vertebral artery on the opposite side gets kinked. If it goes to 45 degrees, the vertebral artery on the opposite side gets completely blocked. Let me show you what I mean by that. So this is the spine. You're looking at somebody from the front. So what happens is when the head is turned to one side, this little red line is the vertebral artery. It's going up into the brain. So at 35 degrees, this artery gets kinked. And at 45 degrees, it gets completely occluded, which means that symptoms show up more with moving the head or rotating the head or extending the head. Oftentimes they present with ringing in the ears, fainting, blurred vision, difficulty swallowing, and the only way to figure that out is to get what is called a rotational MRI of the neck. And I'll give you some more details on it. How do you treat that? Ideally, you start with a neck brace. It has to be a hard brace. And you kind of see the response right away. Physical therapy to strengthen the neck muscles, to give it more support, and to avoid any activity that provokes exacerbation. So avoid sports, avoid activities that might have you either hyperextending or rotating your head and neck to extreme sides on each side. If all else fails, then it's surgical fusion. Now, what happens is with craniocervical instability is that we know that the ligaments are not really working, they're lax. This instability at that junction causes deformation of the brainstem. That's the lower end of the brain, where the brain then becomes a spinal cord. Blood flow is altered. We talked about the vertebral artery. CSF flow is also altered. And then there's the risk of what is called basilar invagination, which I'll show you again soon. Moving down to the lower cervical spine, which is C3 to C7, here the symptoms are very different. There are no more you won't see as much of headaches and the dizziness. Here it is more muscle spasms, there's a cracking sensation in the neck, there's more neck pain, and there might be tingling and numbness in the fingers. So this is called the Barrie-Lieou syndrome. Barrie is from, I don't know if you've ever heard of the condition called Barrie. So this is the neurologist, Barrie, who came up with this Barrie-Lieou syndrome. What happens is, this is the cervical spine. So you can see the spine over here, the cervical vertebra. Right glued against these vertebrae, glued against them is what is called the cervical sympathetic ganglion, or the nerves of the autonomic nervous system. They're literally stuck to this over here. Now imagine if this was unstable, it would be yanking on this cervical sympathetic chain. When it does that, it causes symptoms of autonomic dysfunction. So it is difficulty swallowing, numbness in the tongue, blurred vision, tinnitus, ringing in the ears, dizziness, neck pain, and headaches. The neck pain and headaches is, of course, from the instability. It's called the Barrie-Lieou syndrome. So, I'm bringing up this. It's called Basilar Invagination. In this, what happens is the C2 vertebra looks different. It has, if you ever look at it in real, like there's a really scary looking pointer on it. What happens is, because of the instability, it kind of presses against the brainstem. And so this over here is the hole. So you're looking at the hole through which the brain comes out, and then it becomes a spinal cord. So what happens is that at C2, this starts pushing into the foramen magnum, into that hole, and it squeezes the brainstem over here. And symptoms of basilar invagination are usually, they come on, of course, when your head is bent backwards. So when the head is hyperextended, that's when it shows up. Weakness in the arms and legs, tingling in the arms and legs, again, vision, neck pain, confusion, difficulty swallowing. So again, you see some of these symptoms repeating themselves again and again and again. And we have to kind of stand back and say, okay, difficulty swallowing, is that a cervical instability, or is that basilar invagination, or is that just an autonomic dysfunction, or is it something completely entirely different? So imaging for craniocervical instability is, you need functional imaging technology. Static pictures are not useful. So most MRIs are done with us lying down in a still position. We don't really get a picture out of that. So functional CAT scans, so usually in a flexion position, you take a picture, they rotate the neck to the left and then to the right. Again, functional MRIs, upright MRIs are critical in these cases. And then we can do what is called the DMX, or the digital motion X-ray, and actually see it in live as the head and the neck move. Again, this slide, I put this slide in there because very often people do get upright MRIs, but when they're read by the radiologist isn't quite aware of what they're looking for. So these are the three angles that what you have to specifically ask for. They don't normally measure them because they're pretty time consuming, so they don't normally measure them. But if you request that they be done, so they will do it. One is called what is called the Lieou axial angle, and then there's what is called the Harris measurement. We'll go into these a little bit more, and what is called the Grab-Oaks or the Maidstone-Oaks measurement. If you want to read a little bit more in detail, it's on the latest guidelines on the neurology section. What do you do for craniocervical instability in the mild to moderate version? Neck muscle strengthening exercises, hard cervical collar. Remember I talked about the Barrie-Lieou syndrome? This prolotherapy, technique of prolotherapy called the Hackett-Hempel prolotherapy. I've heard good things. I've have patients come back and tell me good things about it, that it has helped. So you have to be very selective in who you go for. You have to go to somebody who has a fair amount of experience about prolotherapy for this. And of course, in severe instability, the choice is cervical fusion. So moving on to temporomandibular joint dysfunction. This is a really, really, really very common cause of headache in patients with EDS. How cool is that? So these are the muscles of mastication. You can see that that's the temporalis. That's the temporalis muscle, and that's the masseter muscle. And then right deep inside, there are a bunch of other muscles called the pterygoid muscles that help us grind our teeth. And of course, if you see people who have temporomandibular joint dysfunction, they'll have tender points on the masseter muscles. They'll have tender points on the temporalis muscle. The pain from temporomandibular joint dysfunction is in this area. It's in the jaw, it goes in the temples, goes up to the ears, behind the ears, and then in the neck and into the upper back. It also goes into the frontal region. So it's very closely related to neck issues. There's clicking noises. You can feel the joints slip in and slip out. There's clenching and grinding. You'll find yourself clenching during the daytime, grinding at night, pain with chewing, difficulty opening your mouth wide, and oftentimes the jaw gets locked up. It's present in almost 70% of the patients. Again, avoid excessive mouth opening, caution when yawning. It's best to see an orthodontist who really specializes in temporomandibular joint dysfunction. It's not something that, going to any dentist will do it. It has to be somebody who really has a lot of experience in it, because they have what are called oral appliances. They measure you, they put these devices in your mouth. There's some for at night, there's some for daytime use. I don't prefer that using over-the-counter mouth guards, because they don't really fit well. And if they don't fit well, then you tend to grind more. The other thing is they don't really prevent us from chewing down or clamping down. They just protect your teeth from being worn out, but the problem is still there. While I'm on the temporomandibular joint, I wanted to talk about dental issues in EDS. Oftentimes they'll have the teeth are weak and thin, the enamel is thin, what they sometimes call as soft teeth. They are very prone to cavities. There's a lot of gum issues, periodontal gum weakness, gingivitis, they bleed easily. There's delayed healing after surgery, there's tissue breakdown after surgery, gum recession, pocketing, and there's crowding of teeth. And on top of that, local anesthetics may not work, or if they do work, then there's a delayed onset. So dental issues are pretty common. There's a dental gel called Livonex. It's spelled as Livionex. It has a unique way on how it works, and it does help with improving soft tissue around the teeth, so it stabilizes them. It's not available over the counter. I think you can purchase it online. I believe Amazon has it. It's called Livonex, Livionex, something like that. So carie malformation, it's really common in EDS. The ones in red are the more common symptoms. There's neck pain, there's balance problems, tingling and numbness in the hands and feet, difficulty swallowing. There's headaches, which are made worse by coughing or straining. They do present with that. There's ringing in the ears. So they talk about what is called complex carie, and this complex carie is, again, carie malformation associated with sleep apnea, dysautonomia, and associated with neck instability or basilar invagination. That is listed now as diagnosed as complex carie. So what is carie malformation? This is a normal picture. So the brain is inside the skull. There's a hole at the bottom of the skull. This is where the brain then becomes a spinal cord. It's called the foramen magnum. This part of the brain is called the brain stem. In carie malformation, the brain starts to poke through. It crowds through the hole in here, and the brain stem gets squeezed, and the cerebellum gets squeezed. The cerebellum is responsible for balance, and that's why there's a lot of balance issues in patients with carie malformation. So the reason why we're not really sure why people with EDS are more prone to carie. One of the theories is that there's what is called cranial settling because the ligaments are loose, and you have a 12-pound head or a 32-pound head that settles down on the cervical spine. Is that what's causing it? We don't know. Condyles are called joints. This is where the joint of the skull is. It glides backwards, and then these are the angles that they measure. Again, there are a bunch of angles: clivus axial, clivus atlas axis. But the most important is the clivo-axial angle. So again, I wanted to show this MRI to show you what it really looks like and the importance of having an upright MRI. So on the left, you see this is a supine MRI, and here you can see the cerebellum, the flower-like picture. This is the balance. This controls our balance. This is the brainstem here, and this is the clivo-axial angle in a patient in this patient, and it's 141 degrees, which is within the normal range. When this patient sits up and you do an MRI, you can see the cerebellum starting to poke down through the foramen magnum here, and the clivo-axial angle has now become 133 degrees. So this is the reason why it's important to have an upright MRI. Very often the argument is, well, we diagnose carie malformation in patients supine also. How come? Those are patients without EDS. In EDS, it's a different story. The ligaments there's a cranial settling. The head kind of settles onto the neck, and so you can see the protrusion down through the foramen magnum. So again, this is the reason we just went through this. MRI in the upright position is really important, but getting an MRI is not the whole thing. We really have to ask the radiologist to measure these three angles. Let's go down to the pain in the back. The spine, so when I say back, I mean the thoracic and the lower back. The spine is made up of multiple joints. I mean, literally dozens and dozens of joints. All of them are held together by ligaments and muscles. And if you look at the spine, it's basically a stack of bones, all held together by ligaments and muscles. obviously we can't depend on these ligaments to hold us in place. So the muscles have to spasm up. And so when the muscles spasm, that's where you get our pain. In the thoracic spine, the rib actually makes 3 joints. When it meets the thoracic spine, there are 3 joints when the rib meets the thoracic joint. Those are called the costovertebral joints. And, the ribs move a lot. So every time we cough, we sneeze, we breathe, the ribs move. And there's subluxation of the joints between the spine called the facet joints. There's pain from the sacroiliac joint. And oftentimes the pain from the SI joint is, one, the SI joint itself, the ligaments are loose. The second thing is that you have an uneven posture. So if you have what is called an apparent leg length discrepancy, where your pelvis is tilted a little bit, that causes sacroiliac joint pain. This is mostly literally in the butt area, in the back. And again, there could be kyphosis and scoliosis. And it's also a symptom, back pain is a symptom of tethered cord syndrome. So again, the spinal pain in EDS is mostly from muscles that are trying to just stabilize the spine, and there's the subluxation of the joints. So the idea is that, okay, if we correct the posture, if we get the spine in alignment, we use compression garments, do muscle strengthening, it will stabilize the spine. I would not recommend steroid injections in these cases, unless you can do it in very, very select cases if there's inflammation, but most of this pain is basically mechanical. It's not inflammatory pain. This is a great lumbosacral brace. This company, again, any company that I mentioned, I have no financial interest with them. But this is from my practice, I like to see patients use these braces. It really helps stabilize the SI joint and the lower back. So touching on tethered cord syndrome, this is what Dr. Kling often refers to as low back pain with a triad. So low back pain with neurogenic bladder, leg weakness, and sensory loss, and musculoskeletal abnormalities. There was a study that they looked at how common is tethered cord in EDS. So they looked at patients who were diagnosed to have Chiari malformation, and they found that 14% of these patients had tethered cord. But then they were also patients who had their cerebellar tonsils, they didn't quite meet the criteria for Chiari malformation, but their cerebellum was beginning to stick down, and they found that 63% of these patients had tethered cord. So in all total, 77% of patients with EDS can have symptoms of tethered cord. And again, the question is, in these patients with low-lying cerebellar tonsils, is there a possibility that the tethered cord is kind of pulling down on the spine, causing the Chiari symptoms? Again, we don't have any evidence, but this is the general thinking. What is tethered cord? This is so you're looking at a cross section of the spine. This is normally where it ends. The spinal cord ends at L1, which in you would be probably somewhere in the mid back, and then after that it's just a piece of what's called the phylum. It's just there's no nerve tissue. It's just a bunch of connective tissue. In tethered cord, normally this phylum hangs freely, and as we grow taller and as we move, this moves along with us. In tethered cord syndrome, what happens is this phylum is kind of stuck to the bottom of the spine, and it pulls on the spinal cord, and you can see what's called a conus, because it looks like a cone, and it can be lower. Normally it's L1, it can come down to L2. So patients present with aching, burning pain in their lower back, legs and feet. There's weakness in the legs, and it's not equal. So one leg might actually be worse than the other. They have heaviness, stiffness, tightness, they have cramps. This is a very common complaint in these patients, cramps in their calf muscles. Tingling and numbness in the pelvic area or between the legs. There's decreased sensation in the area between the legs. They may have a history of toe walking. Again, if someone gets diagnosed with tethered cord, look for Chiari malformation. If someone gets diagnosed with Chiari malformation, look for tethered cord. They usually will have bladder issues. There's urinary hesitancy. There's increased or decreased frequency. So they go often or they don't go for the entire day. Generally will have urgency. This is kind of important. They have a sense of incomplete emptying of the bladder. So after they finish peeing, it feels like they haven't quite finished yet, and it feels like there's still some left. Nocturia is going often at night. Don't see that too often. More than 3 urinary tract infections in a year is pretty important here. This is a redundant slide. So MRI is not a useful diagnostic tool for tethered cord syndrome, mainly because oftentimes you can't see that the phylum is so, you can't see if the conus is down to L2, then it's easy to diagnose it. But it's not very commonly, it's not a gold standard test. But oftentimes an MRI is done to rule out any other problems that might be arising from the spine. The diagnosis basically depends on a clinical history and examination and doing a urodynamic study for a neurogenic bladder. This is a picture that I got from Dr. Klinga. You can see the spine, the spinal cord. This is below the spinal cord. So you can see this is the covering that has been. That's the covering that has been opened up. She's stuck some little gauze pieces under there, and you can see how tight the cord is. You can see how tight the phylum is. You can see some blood vessels in there, and we're looking into this, and there's also fatty infiltration into the phylum. I just talked about this, how the tethered cord. This is a picture I wanted to show you. So when we're still young, you can see that the spinal cord actually reaches the end of the tailbone. As we grow taller, it moves up along with the spine, so it's connected to the brain. But the spinal cord ends at L1, and then you have the conus there, and then you have the phylum hanging loose and free. In tethered cord, what happens is it's stuck over here, which basically yanks on these nerves. So these patients present with different neurological symptoms. I talked about the neurogenic bladder. There's increased frequency, urgency, but more importantly, it's a sense of incomplete evacuation of the bladder. So what happens is that these patients, when urine starts to collect in the bladder, it starts to fill up. And at one point, what I call as a threshold value, we get a sense that we need to go to the bathroom. It's not urgent, but there's a sense. Oftentimes, because of the tethered cord, because the bladder isn't getting enough of its nerve supply is hampered, that feeling is not there. So what happens is urine keeps collecting in the bladder till it reaches a critical volume, and that's when you have the feeling of urgency. These people go to the bathroom, they empty the bladder, but they don't quite empty it all the way because they don't have full control over it. And so the bladder still is like, it's only half empty. So it doesn't take a whole lot of time for it to fill up again. So that's why they have frequency of urinary, of going to the bathroom. Urinary tract infection is because of urine. There's always a constant level of urine in the bladder. There may be incompetence of the sphincter at the urinary bladder, and so that's why they're more prone to urinary tract infection. This is again a redundant slide. So this is a subject that comes up very often, and there's not much in the literature. So what I'm going to share with you is what I've learned over the last few years, just experience-wise. There's not much. So patients with EDS often complain of not being able to take a breath. It almost feels like they have to remind themselves to take a breath, or when they breathe, they're not really getting a full breath in. It's mistaken as asthma sometimes. They do have pain from ribs because, again, the ribs sublux. There are muscles around the ribs that also go into a spasm. All the testing for heart and lungs are normal. And the other muscle that's used in breathing is the diaphragm. It's a big sheet of muscle that separates the chest from the abdomen. So this is not a great pictorial, but just wanted to show you. So as you inhale, air goes into the lungs. The diaphragm moves down, so the chest cavity expands, so the ribs move out, so the lungs fill up with air. When we exhale, the diaphragm pushes up, the ribs collapse, and so we blow air out. As simple as that. Now, here's the problem. With proprioception, there are proprioceptors in the ribs, in the muscles of breathing. There are proprioception. The diaphragm has proprioceptors. The joints where the ribs meet the spine, there are proprioceptors. They are not telling the brain exactly where the ribs are at a given time. And so whether the ribs are in an inhalation position or in an exhalation position, the brain doesn't quite get those signals. It's almost like being clumsy with breathing. And so what happens is they wind up getting that sense of not being able to get a breath in. They also start to, so some ribs are moving in, some ribs are moving out. They tend to have subluxation of the ribs. The muscles are uncoordinated. And so like everywhere else, these muscles then go into a spasm. So this is what I feel is the reason for breathing problems and chest pain in patients with EDS. So how do you fix that? This is one of the exercises you can do. Lie on your back, and you can put a book or a sandbag over the belly button, and you try to breathe through your belly. So you try to move your belly. So you're moving your diaphragm literally, exercising your diaphragm to get back proprioception on the diaphragm. The other exercise is lie on your stomach on the floor, place a 1.5-inch rubber ball under the belly button. The reason why it's the belly button is because that's the level where the diaphragm actually connects. Lie comfortably in this position for about 20 minutes. If it's uncomfortable before a minute, use a smaller ball. This is the cool part. Again, singing helps symptoms of breathing. Playing a wind instrument like a recorder or a flute, that can help with proprioception of the lungs. So it may help with chest muscle and rib pain. The beauty of this is that it helps with strengthening the lower back, because some of the muscles like the quadratus lumborum and the diaphragm are also responsible for our lower back. And so we wind up strengthening those muscles too. So not only are we treating our chest pain and our breathing issues, our subluxation, we can also treat our lower back pain. Pelvic pain, there are many types of pelvic pains. I'm just going to touch on some of the common ones. Dysmenorrhea or painful menstrual periods, dyspareunia or painful intercourse, and sacroiliac joint dysfunction. There's another one I didn't add over here. It's called interstitial cystitis. Interstitial cystitis is inflammation of the bladder itself. So what do you do for dysmenorrhea, which is painful menstrual periods? Birth control, that's the best thing to do. It also prevents joint laxity, and oftentimes a lot of the symptoms of EDS actually get better with holding off on periods. You can try, for the acute phase, you can try Motrin or Aleve and combine with Tylenol. I did put interstitial. So interstitial cystitis is bladder pain. It may be part of mast cell activation syndrome. We're not quite sure. Again, if you treat mast cell activation syndrome, we're hoping that this might help. And, when I know, so there was a talk recently that Dr. Maitland had given on mast cell activation syndrome, and you can get a lot of information, great information on that. This is my 2 cents on it. There's a drug called palmitol ethanolamide. In short, it's called PEA. This is a drug. It's a kind of a weird drug. It's not a prescription drug. You can get it at this website. This company has for the first time brought it to the U.S. It's been around in Europe for many years. They have done some great work on using it for pain and mast cells. It's worth trying it. It's both in as a pill and as topical, but not for the bladder, obviously. But topical, if you have a joint pain or muscle pain or nerve pain, it does work topically quite well. Dyspareunia or painful intercourse, again, this could be from mast cell or it could be from EDS itself. Hyaluronic acid, there's a paper on it also. You can locally put in some hyaluronic acid. You can get that on Amazon. And that really works well. The beauty of hyaluronic acid is that it attracts, when you put it in the body, it attracts 1,000 times its volume of water. So it really liquefies that area. So moving from the torso, let's move to the pain in the arms, shoulder and arms. Now, shoulder pain and arm pain can be from shoulder subluxation or dislocations. It can be from thoracic outlet syndrome. It can be, again, from the usual tendonitis, bursitis, or hyperextension of the elbows. Wrist and finger pain can be from the subluxation, muscle pain, tendonitis. Shoulder pain, so besides the muscles, remember I told you about how when a joint subluxes, the muscles around the joint will start to spasm up, and that's usually the reason. But there's also another reason. It's called thoracic outlet syndrome. This is the distribution of pain in thoracic outlet syndrome. As you can see, it looks classically like somebody with neck pain going down the arms. And it's very often missed. This is a little 2-minute anatomy on this. So if you're looking at somebody from the front, this is the collarbone. This is the shoulder joint here, and this is the first rib over here. So between the collarbone and the first rib, there are a bunch of nerves, arteries, and veins that travel down to the arm. So they're called the brachial plexus. This bundle of nerves, arteries, and veins, they sneak in under the collarbone, over the first rib, down into the arm. In thoracic outlet syndrome, what happens is that if this muscle was to go into a spasm, or this muscle go into a spasm, usually it is this muscle, then these nerves or the artery or the vein can get compressed. It can also happen from the collarbone subluxing. It can also happen from the first rib subluxing. There can be an abnormal first rib that can also squeeze this. But that's the usual cause of thoracic outlet syndrome. But in Ehlers-Danlos syndrome, it could be from it can be from compression of the subluxation of the collarbone compressing the scalene muscle. The brachial plexus going down to the arm. So classically, patients would present with upper back pain, neck pain, and going down the arm. It's a very easy diagnosis. Anybody who's familiar with it can do it. A physician can do it in the office. Physical therapists are really good at diagnosing it. The treatment is, again, physical therapy, kinesio taping, Botox injections to loosen up the muscles, and if all else fails, surgical correction. This is the kinesio taping for the shoulder joint itself, not specifically for thoracic outlet, but for the shoulder joint. So moving down to the hands and wrists. Now, again, So this goes back to proprioception, the basics. As you can see, imagine if my brain didn't know the exact position of my fingers and how tight or how loose I was holding something. The patients with EDS tend to grip things tightly to compensate for poor proprioception. As a result of that, you see all these tiny muscles in the hand, they get tired and they start to hurt. And not only that, they also tend to sublux their joints over there. This is a classical way how patients with EDS hold a pen. They literally wrap their fingers around it. If you have kids who do that, it's okay. They can do that. That's fine. There's no harm done. What they're trying to do is they're trying to use as much of the skin surface to hold the pen, feel the pen, and that's how the brain bypasses proprioception. They don't get, when they press down, they don't get that feedback from the pen moving or the pencil moving on paper, what is called as haptic feedback. They don't get that, so they tend to press down harder on paper when they write. So all this abnormal pressure, gripping the pen hard, pushing down hard while writing, causes subluxation and pain in the muscles and joints. Again, this is going back to what's broken. We need to fix. How do we fix this? This is foam padding. It's pretty easily available everywhere. There's a company called Ableware. They make it for pens, forks, knives, toothbrushes, for everything. If not, you can use a foam padded tape and you can wrap it around the pencil. It's made of dense foam and it gives them a better grip and it doesn't cause as much strain on the joints and the muscles. They can use compression half finger gloves. If there's instability of the joints, then bracing it would be the way to go. So these are splints for fingers that can be used to stabilize the finger joints. So I just want to touch a little bit on splinting and bracing in general. So the purpose of putting a brace is to maintain the joint and align the joint, to maintain it in a neutral position. It's to avoid any hyperextension or any lateral movement of the joint. It's just to let it move the way it's supposed to move. They do, as a side benefit, help with proprioception because, again, it helps with the contact. When you start using a brace, start using it gradually. So start using it like an hour a day for a few days, then 2 hours a day for a few days. Sometimes kinesio taping along with bracing is a great option. The big argument is, do braces make muscles weaker? And this is a very common misconception. No, they don't. On the contrary, they actually help muscles. There is absolutely no research to show that braces make muscles weaker. There are no braces that are so tight that they stop the muscle from moving. Braces are usually around joints. They just stabilize the joints so the muscles can move more efficiently. If you have a joint you don't want to move because it's painful or it's because it's subluxing, your muscles are more likely to atrophy. But if you put on a brace that stabilizes the joint, then you're going to be moving the muscles even more. So I'm going to move down to legs and knees. One of the key things to remember is that if the feet, the most important thing is to look at the feet and ankles. If the feet and ankles are unstable, then they make the knees even more unstable, which then makes the hips unstable, which then throws the pelvis and spine off. So I wanted to show you this. So if the ankle and feet are unstable, that makes the knees unstable, which then makes the hip unstable, which then makes the muscles contract, and then it throws the spine off. So it starts as a chain reaction from bottom up. So that's why I'm going to go straight to ankles and feet. Here you can see flat feet is very common. It's predominantly in EDS is usually the 4 feet that are flat. So if you lift up your foot, it may look like you have a great arch, but the minute you put weight on it, it collapses. The problem with having flat feet is that it causes overpronation. So you see this, the weight on this foot is literally not even going through the ankle, it's bypassing the heel completely. You can see how this is turned out over here, and so it's bypassing the heel, not completely, but almost. And that's where the problem comes in with ankles, with flat feet, both for ankles and as well as for feet. So the idea behind doing this is that in a normal foot, the weight is, when it's aligned, there's equal distribution of weight. When it's misaligned, then the weight is off the foot. Some of the exercises that you can do for feet is barefoot walking, where it's safe. Because when you walk barefoot, we tend to move our toes, we tend to grip the floor with our toes, and that kind of helps strengthen the muscles in the foot. Ankle raises by lifting the heel, but not leaning forward, and then you come down slowly in a controlled way. This is very important. Shoes. The best thing I can say about this is to wear sneakers. So you have to wear shoes that have laces on them, and they have to support your heel as well as your forefoot. Orthotics for flat feet, again, the reason we need orthotics is again to stabilize the ankle as well as the foot. Start using them really slowly, 1 hour a day, and then for a few days, and then 2 hours a day, and so on. Now, when you buy a shoe, there are literally dozens of orthotics in the market, ranging anywhere from $10 to $1,000. But there are 3 key things to look at. It should have a deep heel cup. The material should be firm, not soft, not gel. It should be firm. It shouldn't distort. When you put your weight on it, it shouldn't change its shape. And it should have a supportive arch. These are the key 3 things to look for when you buy a shoe insert. Ankle bracing is a great way to stabilize the ankle joint, especially if you're having knee and hip pain, and it could be from an unstable ankle joint. So as we move up, we're moving up to the knees. I think almost all the EDS patients that I've seen so far have an unstable patella or the kneecap. I just want to show you something. This is the kneecap. There are 4 muscles over here. These are 3, there's one below this, that connect to the kneecap. And what happens is, because the kneecap glides, in EDS it glides so much laterally and medially, it tugs on these muscles. And that's why oftentimes these patients have pain in the front of their thigh. That's the region of the pain. You can see the blue area where they have their pain. So treatment options for knee pain, stabilize the feet and ankles first. Make sure your feet and ankles are stabilized. Then talk about strengthening the muscles around the knee. These are really easy exercises that can be done. Even if you're having a bad potsy day or a bad fatigue day, you can do them lying down. The key thing over here I wanted to show you was in a knee brace. What's so special about this knee brace is that it has 4 straps. So the leg is conical in shape. So the thigh is has a higher diameter up here as compared to here, and the same thing here. So what happens is standard braces that you get over the counter don't really function for that. So they have this strap. It should have a strap in the front, and then it should have a strap in the back. And the same thing for the lower end. It should have a strap in the front and a strap in the back. So that really forms to the contour of the knee or the thigh and the leg to hold it in place. It should have a little donut over here to keep the patella stable. It should have a metal strut over here which is adjustable to prevent it from hyperextending. So these are the things to look for when you get a knee brace. This is a very missed cause of leg pain, and it's very common. That's why I'm bringing it up. And for some strange reason, there's very little literature on it, and so hence this joint is actually often called as the poor cousin of the knee joint. Patients with this condition present with pain. It's in this region. You can see in the picture over here. It's inflammation of the peroneal nerve, and oftentimes these patients will develop what is called a foot drop. The foot drop may come and go. The way you know that you have a foot drop is when you're walking, when you've been walking for some time and the pain is pretty bad, the toes get caught in the carpet, and that's how you realize that you're getting a foot drop. This is to show you the anatomy of what it looks like. So this is the knee joint here. This is a bone called tibia, and there's a little bone on the side called the fibula. And so this part is kind of just the area just below the knee. And this is the outside of the leg. This is the inside of the leg. And there's a joint over here where this fibula meets the tibia. And this is a nerve that winds around the fibula, and then it comes and splits down and it goes down to the leg. And this nerve is responsible for moving the foot up. As we walk, it clears the foot off the ground. It's also the sensory nerve for the side of the leg. What happens is, again, that joint is prone to subluxation like all other joints. Let me just get a sip of water. So when that joint subluxes, it hits this nerve. So this is the sublux joint. It taps on this nerve again and again and again. And so this nerve gets inflamed. And you wind up having pain on the side of the leg with the foot drop. Almost everybody gets diagnosed with IT band. I'm sorry, that spelling is wrong. It's an iliotibial band. It's a band on the side of the thigh. It goes from the hip all the way down to the knee. It's connected to the knee joint. Up here, it's connected to the hip muscles. It's often a cause for this band over here. This is the iliotibial band. You can see this over here, IT band. And there's a muscle that connects to this IT band. So it kind of holds up the IT band, tightens it. Again, this is connected. This comes to both joints, the hip joint and the knee joint. And so if the hip is unstable or the knee is unstable, then this IT band gets tugged on, and so there's pain from the IT band itself. The treatment for this is not stretching the IT band. Oftentimes I've seen people stretching, and they use a roller or a roller to stretch that IT band. The treatment is to figure out what's broken over here. What's the problem here? Is it the knee? Is it an unstable knee? Is it a hypermobile patella, or is it the hip that's causing the IT band to spasm up? Same thing with the trochanteric bursitis. Remember I told you how the bursa. So this is a bursa that's on the side of the hip. Very common cause of pain. The way you know that is it gets worse when you lie on that side. Getting up from a chair while being seated for a while, you get pain there. Again, it may be because of an unstable hip or an unstable knee. Remember, just to refresh you, bursitis happens when the joints have subluxed. The muscle gets stretched, the tendon gets stretched, and then the bursa under it gets inflamed, and that's what a bursitis, trochanteric bursitis is. So, moving on to abdominal pain. Abdominal pain is actually very common in EDS. We know some of the reasons. There's gastroparesis that is slowing down the intestines. There's laxity of the intestines. There's prolapse of the internal organs. And then, of course, there are the hernias that are very common. Mast cell activation syndrome is a very common cause of GI motility issues. Again, the intestines are also controlled by the autonomic nervous system, which is again responsible for dysautonomia. So is it mast cell or is it dysautonomia? That's what we need to figure out. Motility can be either fast or slow. They also have acid reflux, which is usually part of mast cell activation. Hence, the recommendation is to use H2 blockers. No, I think we'll be okay. I have another 10 minutes to go. There's something called rectal evacuatory dysfunction. It took me a while to figure what they meant by that. So it means that when you sit on a potty for a bowel movement, oftentimes patients with EDS have to kind of reposition themselves. And the reason is that because of the laxity of the intestines, because it's heavy, it's loaded, it's heavy, it flips to one side, so they have to sort of reposition themselves to be able to do that. This little device called the Squatty Potty helps quite a bit. One of the things that's been bothering me is this term called functional GI disorder. Now, officially, the term functional GI disorder is pretty straightforward. It is not psychological. The gastroenterologist has said that this is not psychological. It is a functional GI disorder. But oftentimes, gastroenterologists who don't really understand this or don't really understand EDS use it as a term to imply that the abdominal pain is psychological. So you have to be very careful about that. Again, one of the issues about GI pain is gastrointestinal system can cause in chronic pain. The diversity of the bacteria can change. Normally, there are about 1,000 different types of bacteria. We know that in chronic pain conditions, this diversity goes down significantly. This then causes inflammation of the lining of the intestines, which is then damaged, which then releases these nasty fellows called pro-inflammatory cytokines. There's something called the TLR4 receptor activity that is increased, which has been known to be associated with inflammation. I'll talk about LDN on my next meeting, but LDN is one of the drugs that works on the toll-like receptor. And so it may be one of the ways that it can help pain. I'm sorry, this slide is from a different presentation, but very often patients with GI issues have what is called a small intestine bacterial overgrowth. It's too lengthy to explain over here, but when patients have GI motility issues can have what is called basically bacteria that are in the large intestine start to move into the small intestine. They're not supposed to be there. And so they're called small intestine bacterial overgrowth. To test that there are ways to test it. The easiest one is what's called a breath test. So you literally have to breathe in these tubes and then they measure the contents of those tubes and can figure it out. And then, obviously talk to a gastroenterologist about how to treat it and diagnose it. This is a paper. It is actually a case report that we wrote sometime back with Dr. Weinstock on. Can you hear me still? Can you hear me?
Yes, we can see the paper you have up and we can hear you.
Okay, great. So this is a paper that we wrote for, this is a patient with EDS and CRPS, and it was diagnosed as small SIBO. In the new recommendations on the GI paper, there's a recommendation for using low FODMAP diet. FODMAP stands for fructose oligosaccharides disaccharides monoamines polyols. And then there's our trial of gluten-free diet. And of course, if it's mast cell activation syndrome, think of oral cromolyn. Just a caution, nothing to do with the GI tract, but antibiotics of the fluoroquinolone family are not, we don't recommend them in EDS. They're often used, one of them is called ciprofloxacin, levaquin. They can cause tendonitis and tendon rupture. Surgery is not a great idea in EDS. Again, I told you why, because if this is what it looks on the skin, imagine what it looks inside, how it heals, especially if it's a weight-bearing tendon. A little caution about behavioral issues. Almost most people with EDS go through this. Just to show you figures, conversion disorder incidence is less than 1%. Munchausen by proxy, the incidence is 0.5 out of 100,000, and the incidence of EDS is anywhere between 1 to 10%. Obviously, conversion disorder and Munchausen by proxy is far more rare than EDS, yet we're very quick to diagnose people with these two conditions. Again, to diagnose a child with any of these is you really need a multidisciplinary team approach where they have to follow the child for weeks and months and years even, and have concrete evidence that there's nothing organic there. Oftentimes, a physician may just see the patient for the first time, in 10 minutes comes up with a diagnosis of conversion disorder or Munchausen. It's really very harmful, and what it does is it really closes doors to all proper treatment. I think we can end over here. I don't think we have more time to go through, right?
That would be a good stopping point.
Yeah, let's do this.
Okay. Thank you so much for presenting for us again tonight. And we look forward to the second half, which will be in May. And we will update everyone on what date that will occur on. And if you'd like to sign up for announcements, we'll send an announcement out to everyone. If you go to our website at edsawareness.com, you can click on the registration for email alerts, and that is where you see the free guide. Sign up there. So we're going to go ahead and wrap up since it is about 9:30 here Eastern Time. Just wanted to let you know that everyone that is attending live tonight is very appreciative of all of your time and valuable information that you presented tonight, Dr. Chopra, and we really do appreciate how compassionate you are to our patients. And yes, thank you so much. And some people are asking how we can get in touch with you. Would you want them to phone your office if they need to reach you? Would that be the best way?
Oh, my contact details are at the last slide. Can I just jump to the last slide?
Oh, certainly. Yes, you should be able to. There you go. Okay, so the people who were live attendees and asked about that, they can send emails to painri@yahoo.com. All right, and then if John's on the line, I'll go ahead and let him close out the meeting if he'd like. I don't know if I have John. Okay. Well, wanted to let you know that this meeting is sponsored by our online store and our nonprofit Chronic Pain Partners and EDS Awareness. We do offer many products in the online store, which the proceeds go directly to fund these programs. So feel free to check that out, and that is at bodysupportstore.com. And thank everyone for joining us tonight, and we look forward to part 2 in May. So have a good night, everyone, and again, thank you, Dr. Chopra.
Thank you very much for letting me do this presentation. Thank you very much for attending. Good night.
Good night, everyone.